Hello, my name's Florence. Welcome to theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 83. An average Monday. Monday is my labour ward day. I'm on labour ward from 8 o'clock in the morning till usually about 6 in the evening. 10 hours. Week in, week out, unless I'm on leave. It's my day to day. But for the women and families that I'm looking after, it's anything but an average day. This isn't typical. This is there once, twice, or possibly a handful of times in their lifetime that they will be on the labour ward. Today, I thought I'd explore a little bit what my average Monday is like, give you a little bit of insight. And part of the reason I've been thinking about this is because of something that was said in my friend Jill's podcast, Wildcard Who Shoes, when she was talking to Rachel Grimaldi of Card Medic. Rachel talked about the idea that the patient in front of her should feel that they were the only patient that she's caring for, to the exclusion of all others. And I've been thinking and reflecting quite a lot since I listened to that podcast a few weeks ago about whether that's true for the women I see and care for on a daily basis. And I think in some situations it's not actually practically possible. However much I would like that woman, that family, to feel that they are the only people needing my attention, the fact is that when I'm on the labour ward, I have multiple issues competing for my attention, whether that's other women on the labour ward, other members of staff, other tasks. And so to give that a little bit of context of why it's not as simple as it sounds, for you to make sure that the person in front of you feels that you're the only person you're caring for, I thought I'd give a bit of context about my day. Because this is also an issue for other members of the team to understand. Midwives, on the whole, provide one-to-one care in labour. They are exclusively with that woman in her labour until the birth of her baby and for a short time afterwards. During their shift, if they're on the labour ward, they may look after maybe 1 or 2 women. If a midwife is in charge of the labour ward, then she, like me, has to multitask. She has to think about a number of women at the same time. And that would also be true for a midwife in theatre, perhaps, who's performing an elective caesarean list as her job for the day. So some of us on the MDT, anaesthetists, paediatricians, obstetricians, and the midwife in charge, or the team leader in charge of an area, will be looking after or overseeing the care of multiple women at any one time, in contrast to some of the members of the team, particularly midwives, who may be looking after only one woman at a time. Right, Monday. How does it begin? My working day does not start when I arrive at work. Part of the importance of how I can manage my day is setting myself up before I leave home. The initial part of my Monday is therefore a couple of important things. First of all, packing a lunch. It's very unlikely that I will eat if I don't bring it with me. I need to bring it with me. I need to have sufficient to keep me going throughout the day. So the first thing is lunch. Hugely important. And I usually prepare it the night before. The second thing that sets me up for my day is taking my dog out for a short walk. And that might seem trivial, but actually in the time between waking up and setting off for work, taking my dog out clears my head, makes sure I'm awake, grounds me in the present. I might meet other people with their dogs, but I certainly notice the changes of the season. It sets me up ready. I'm alert. I'm fresh. I'm ready for my day. I'm lucky. I'm able to drive to work and I have a relatively short journey. This is important because when we're starting off a shift, which is potentially full of difficult decision making and stressful acute situations, it doesn't help if we've had a stressful journey to get there. And I know this is difficult for members of staff who arrive by public transport. Perhaps their train was cancelled or delayed. Everything then starts on the wrong foot. When I arrive at work, the first thing I do is change into scrubs. We generally wear scrubs on the labour ward because you're going to be called into emergency situations at the drop of a hat. And although you can go in your civvies, it isn't great when you end up with blood or meconium on your clothes. So I go into the changing room and I change. And usually in the changing room, there are people that are coming off the night shift. So you get a sense of how the night's been, what's going on. And then you go to the handover board. And we have a comprehensive handover, which I've talked about in episode 18. We'll meet and greet the team who are on for the night. We'll ask how their night was. They'll give us a very thorough handover. We'll figure out who's on for the day and who's responsible for what tasks. If I'm lucky, there'll be a consultant colleague who's helping doing the planned caesareans, who may or may not have an additional junior member of staff with them. There might be 3 or 4 cases. They could be straightforward or complicated. If I've got a colleague doing that, then I can forget all about them for the morning. But if I'm in charge of those, I've got to juggle that workload alongside the labour ward. After we've done our clinical handover, knowing what's the staffing, midwifery, anaesthetic, obstetric, and what's the bed situation is key. Then we know what are our clinical priorities and what are our priorities just to keep things moving. Often, the most junior doctor, the specialty trainee 1, 2, or GP trainee will go off and start doing the postnatal ward round. They may need some support if they're not experienced in postnatal care, and they'll certainly need some help reviewing some of the more complicated women. There will often be 4 or 5 women in labour on average, and we'll need to go in and see them and make plans of what's happening during the day. And usually 2 or 3 women who are in our high dependency unit. We may need to review management of their blood pressure, review their blood loss. Do they need a blood transfusion? Perhaps remove a vaginal pack if one was left after stitching, and decide who is safe to go to the postnatal ward. If I'm managing the planned caesareans and the ward round, then I'll need to take consent from the women having caesareans, and I'll need to juggle the ward round with the WHO team briefing. This is a safety briefing where we all introduce ourselves as members of the team. We discuss the cases. What are the anaesthetic issues? What are the obstetric issues? What are the plans? And we'll decide the order of the list. If I'm doing both tasks, then I will often do the WHO team brief prior to the ward round so that they can get the first woman into theatre and get on with giving her anaesthetic. If I waited till after the ward round, the whole day might run away from me. Usually at some point during the ward round, the test call goes off. That's the emergency test call that I talked about in my episode on emergencies help, and various members of the team will need to leave the ward round to go and respond to switchboard and confirm that the test call has been effective. We do the ward round in the order depending on clinical priority. We may have to miss out women who are having an epidural sited, for example, and come back to them. And as we go round, it helps me to think about who they are, what their name is, to kind of get into my memory who's in which room and what their story is. I also will start to gauge a bit of an idea of who's going to have their baby during my shift. What am I expecting might happen, and how worried or not am I about them? If there's a woman who's pushing, she's in active second stage of labour, I might send in the midwife in charge to find out how is she doing. Is the top of the baby's head, known as the vertex, visible? If she's been pushing for an hour, is the baby's heartbeat stable? Is she doing okay? Is it likely the baby's going to be born without our assistance? And if we are going to be contemplating assistance, how likely is it we'll be able to assist in the room? Or will we need to go to theatre? At this point, another doctor will come and report back to me from the antenatal ward round. There they may be telling me about another 10 women with clinical information. Some of them will be ongoing inductions of labour, but some of them may be new admissions that have come in overnight, perhaps with bleeding problems or abdominal pain or preterm labour. Others may be long stay patients with chronic problems such as a bleeding placenta previa or severe preeclampsia. Interrupting all these things, it may be that the emergency buzzer goes off. The most common reason for that would be maybe a hemorrhage, postpartum hemorrhage, immediately after the birth of a baby, or a neonatal resuscitation call. Periodically, another doctor who's on call for our day assessment unit will pop up and down with a set of notes discussing cases, perhaps of 2 or 3 women who may or may not need admission. These may be women with raised blood pressure or preterm ruptured membranes, that is broken waters. They will come and ask my advice, show me blood test results or fetal heart traces or scan results, and ask me to make a plan. Then I may get a message that they're ready for me in theatre to go and do a caesarean. So I may go into theatre and do that. Sometimes when you're operating, that time in theatre is uninterrupted. But there can also be situations where someone will pop their head through the door when you're in the middle of quite difficult surgery and ask you a question about a completely different case. Florence, are you happy for so-and-so such and such to move to this ward? Florence, those blood results are this. What would you like me to do? When I come out of theatre, I'll go back to the board, reassess what's happening, catch up with the midwife in charge, and glance through the central monitoring system we have to look at the baby's heartbeat traces and see what's happening in each individual room. There's a constant flow of specialty trainees and more junior midwives asking me questions, asking for support, asking me to make plans for individual women. Maybe I'm asked to fresh eyes a CTG, that's an hourly review, and go through it with a junior colleague. If I'm lucky, the fantastic support workers may make me a cup of tea or make a tea trolley. Or we may do a coffee round where we make a whole shopping list of orders and one of us sets off to the hospital coffee shop to buy coffee to keep us going. At the beginning of the shift, I will have identified with the specialist trainee doctor that I'm working with what competencies they need signing off. Do they need me to supervise repair of a 3rd degree or severe tear? Do they need more experience doing a forceps birth? Do they need a more complicated caesarean? So as we go through the events that happen that day, we'll divvy things up depending on what different doctors need or what their level of training is like. For example, a very straightforward caesarean in a woman who hasn't had one before, I can do with a relatively junior trainee who's doing uncomplicated caesareans. A more complex caesarean in a woman perhaps with placenta previa or a preterm baby, I may supervise a very senior trainee who's almost about to be a consultant and therefore is ready to do more difficult cases. In each situation, I will have talked to the trainee about what level they are, what experience have they currently got, are there any particular aspects of the surgery that they're working on, are there any aspects of the surgery that they're having problems with, and we'll identify between us how and when I might take over if needed. As we operate, I'll be making comments, hopefully constructive, to help them to improve their surgical skills. It's really wonderful to see their skills progress during the time they're with us, and particularly if specialty trainees come back to us more than once, to see them going from being a very junior trainee, able to do only very simple procedures, to developing significant experience and being able to do much more complex cases. At the end of a case, I'll give them feedback about how it went, what went well, what they might need to improve. And then they'll send me what's called a workplace-based assessment for me to complete at the end of the day, so that they've got a record of it for their training portfolio. Often it might be 2 or 3 o'clock in the afternoon before I get to eat. Hence the fact that my packed lunch is important. If it's a long time before I'm going to be able to eat my lunch, I'll often snack on a banana or an apple, something to keep me going. Otherwise, you kind of run out of steam by the afternoon. As consultants, we don't tend to have a designated break. It's more that we're kind of eating on the job. I might be in the consultant office, but again, while I'm eating, I will no doubt be interrupted on multiple occasions. As women birth their babies, they're moved off to the postnatal ward, and extra women arrive and get settled in. We need to see them as they arrive, understand what they're there for. Maybe they're in the process of an induction. Maybe they've come in spontaneous labour, but they've got a problem, and that's why they're on the labour ward. So the 10 or so women that I will have seen on the ward round in the morning will be different by the evening. A bit like a Venn diagram, there'll be some intersection, Some of the women will be the same, but some will not. Sometimes it's a little frustrating. You're handing over in the evening and you're feeling as if you've achieved nothing at all, because when you hand over, everyone that you worked hard to support through their birth during the day has already left the labour ward, so it looks as if you've done nothing. The labour ward board is the hub. It's always where we gravitate to, checking back, because it's constantly being updated by the midwives that are giving one-to-one care. They'll come out and tell us how things are going in that room. How is that woman doing? How's her labour going? Are there any concerns about her baby or about her contractions? What pain relief does she want? Perhaps they're popping out to get epidural top-ups, for example, or pethidine. I perform ECVs, external cephalic version, in my labour ward session. I have 2 appointments, one at 12 and one at 2. These women may turn up for their appointment. I need to scan them, see them, talk to them about the procedure, consent them. The midwives will do a set of observations and the baby's heartbeat monitor, and then we'll be able to go ahead. I've got to time how I'm fitting those in around all the other things that are going on, particularly as I need to give a drug to relax the womb called terbutaline and allow it to work for 15 to 20 minutes or so before I start trying the ECV. Sometimes when I'm in theatre, finishing off a caesarean or an assisted vaginal birth, I'll ask the runner in theatre to ring the labour ward and tell them that I'm ready for the terbutaline to be given, so that when I come out, that woman is ready for me. I may be called to other areas of the unit, such as triage, either to see a woman that's come in, or maybe a postnatal readmission, a woman who's got mastitis or a wound infection that needs looking at. A community midwife might ring me for advice. She's doing a home visit for a woman that's postnatal, and she wants to know what she should do about a woman's blood pressure medication, maybe. I may also, these days, need to see a woman elsewhere in the hospital, perhaps in intensive care or the acute assessment unit, because she's in hospital with COVID but happens to be pregnant. Sometimes the workload is too difficult for me to leave the labour ward, so I'll ask one of my other colleagues who's perhaps over in a different part of the hospital if they can pop by and see those women instead. This is particularly the case if I've got a relatively junior specialist trainee with me who needs a lot of supervision. I can't leave them on their own and go off to another area of the hospital, leaving them unsupported. I may need to have conversations with other specialists. For example, I've got a woman that's having a difficult time postnatally, problematic recovery from a caesarean. I might need to talk to a radiologist or a surgeon about CT scan imaging or a return to theatre. Or I may need to talk to one of my medical consultant colleagues if I have a woman who may have a pulmonary embolus and needs treatment. Throughout the day, we're doing our best to try and anticipate problems. Partly, as I said, I'm thinking about what I'm expecting to happen to each woman as I meet her, when she might have her baby, and what issues might arise during her labour. But the other aspect is trying not to let everything come to a head all at one time. Often you can anticipate and prevent that happening. And you might think that that's a bad way to manage the workload on the labour ward. Is it in the interest of each individual woman for them not to all give birth at the same time? Does it matter? Well, it does if they need assistance, because the reality is we have limited resources. We're very lucky. We've got 2 obstetric theatres, but it's not always possible to fully staff 2 at the same time. So if I can stagger things a little bit, prioritise who needs urgent intervention and who could wait a little bit longer, I will. Because that's the reality. We don't have infinite numbers of doctors, an infinite theatre capacity, an infinite anaesthetists. So managing that workload so that the maximum number of women are the safest at any one time is vital. Other things we can anticipate are development of fetal heart changes. We can see the early warning signs when something might be happening. And in my hospital, we use STAN analysis. Often we can see from the physiological changes the baby is making that that STAN event is going to happen. We can anticipate it and change something, perhaps turn off the syntocinon hormone drip or change the woman's position to try and prevent it getting to that point. We can also anticipate the development of infection, chorioamnionitis. Sometimes the woman will start shivering or her heart rate will go up well before her temperature or before her baby shows any signs of infection. We can think, she's developing chorioamnionitis. We can instigate treatment and decide whether intervention is required at this point or whether we can wait, giving everything the benefit of the doubt to see if it then reveals itself or not. Midwives may pop round from the antenatal ward. New women have been admitted, or they have concerns about a woman that's bleeding or that they think might be going into labour. If it's preterm labour, it's important that we check the presentation, which way up is the baby. Make sure that the woman's had antenatal steroids. Make sure we've informed the neonatal unit and get everything prepared, as well as starting magnesium sulfate that's been shown to reduce cerebral palsy rates. So my day is a constant situation of multitasking. And even when I'm in a room with a woman or in theatre with a woman, people may be interrupting and asking me questions, however much I might want to devote myself to that one case. Sometimes being a consultant is called a helicopter view, and it's the same for the midwife in charge. Part of my role is to be that helicopter. Part of my role is not to get focused on one case and one woman. Part of my role is to oversee the whole labour ward, the whole maternity unit, and to be able to take that step back and take decisions and use the staff and the resources appropriately. When it's not possible to take that step back and have that helicopter view, that's actually when sometimes safety issues arise, because we lose that helicopter view. And so in situational awareness training, we will actively pass that helicopter view. So if I'm going into theatre, I will tell the midwife in charge, I'm going into theatre. Whilst I'm in there, you've got the helicopter view. I need you to oversee what's happening to the women in room 25, 30, whatever it might be. And then when I come out of theatre, I will check back in and see what's happened in my absence and retake up that helicopter view. Handover is at 5, but often my colleagues are late. Not their fault. They might be operating on a gynecology operating list or doing a full clinic. They may have got held up. And I may be held up. If I'm literally about to assist in a birth at 5 to 5, I'm not going to walk out and leave her to somebody completely different. I'm going to finish the job. So more often than not, I'm handing over and leaving by about 6 or 6:30. As I leave, I will have had an influence on the care that probably 20 or so women have had during the day. It may be, on average, 7 or 8 women will have had babies. And I may have had a direct hand in just a small number of those in terms of actual hands-on birth, perhaps a couple of caesareans and a couple of assisted vaginal births, but I will have had input to many more. And there will be many more who haven't yet birthed their babies, but I have had input into their labour or the events leading up to their labour. So there you have it, an average Monday. When my children were little and I took them to school, one of the things we used to play was the Bangles, Manic Monday. And in some respects, you may now be thinking, just like the lyrics, just another Manic Monday. But it isn't, even though I've described quite complex multitasking. It can be far from manic. It can be lovely and calm. And I think sometimes women in the birth rooms are oblivious to everything else that's going on and everything else that's happening outside. I will hand over and change and go home. And when I get home, often my brain is full. It's full of the events that have happened during the day. I may have had a number of adrenaline bursts, acute events, things that were difficult, things that were stressful, things that were emotional. And I used to find it sometimes hard to come in, click into mother mode and look after my children, be home. But now my children are grown up, I don't have to take on that role as soon as I come in. And actually recently, in the last year and a bit, during lockdown and the pandemic, I've taken up yoga. So when I come in, the best thing I've discovered at the end of my labour ward day on a Monday is to transition myself from work to home by doing a short yoga video, maybe 20 or 30 minutes. It relaxes me. It stretches my tired muscles and limbs. It calms my breathing, gets rid of the stress of the day, and sets me up for an evening with my husband. My zesty bit this week is to reflect on the difficulty of the reality of being responsible for the helicopter view and the situational awareness and safety of a significant number of women at any one time, as opposed to that idea of the woman feeling I am devoted totally to her and she is the only person I'm looking after. And there will be moments in my day when that is feasible and possible, but they will be fairly far and few between. And I hope that this account of my average Monday will have given you a bit of a feel for why that is difficult. And it can't ideally be how we would always like it to be. And that there is value in some of this multitasking. Actually, someone does have to have that step back and that helicopter view. And it is a complex job being an obstetrician on the labour ward. And I think sometimes we can underestimate that. Even just jotting down some thoughts over the last few weeks on my Mondays to think about this episode, it's made me reflect, wow, that's a really quite complex job that I'm needing to do week in, week out. And how does that become routine and familiar and comfortable? I'm well in my comfort zone. That's my typical Monday. But how do I continue to make it special for those women that are there on that particular day? And maybe that's why there's so much importance on midwifery-led care and midwifery continuity, because actually, as obstetricians, we just can't have that one-to-one relationship with that woman, or at least not in the NHS. But our midwifery colleagues can. And maybe it's just that in my role, in my specialty, my job is a bit different, and not to always have that complete one-to-one connection. But to know that if a midwife has that with that woman, I'm an adjunct to that. I'm a additional person behind the scenes. And sometimes I'm on stage, as it were, but sometimes I'm just enabling and moving things around, hidden from view. And maybe that's okay. As long as that woman, that family has a person who's totally focused on them at that time, and then the other people come in as extra on top of that, that's all right. Food for thought. It would be interesting to know what other obstetricians think, and also what happens in other areas of the world, I guess. So maybe if you're listening in another healthcare setting, drop me a message on Twitter or Instagram. Give me some feedback. What do you think? What's it like where you work? I love to receive your messages and feedback. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FW or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.